to invite Dr. Sucheta Parija for her topic, Approach to Optic Disc Edema, Diagnostic Pulse.
Uh, and Thank you, the organizer, for giving me to talk on approach to disc edema, diagnostic pulse. I have no financial interest in this presentation. So as we all know, if there is an injury to the optic nerve, either it swells up or there is a pallor. So this optic disc swelling is usually a manifestation of a broad range of processes which affects the optic nerve head and the anterior segment of the optic nerve, and it can manifest the fundus picture. You can have a variety of fundus picture. So to clinching on the diagnosis, you have to be very careful and meticulous in taking the history, the clinical examination, and as well as correlating with other systemic examination and looking at the fundus picture. Also taking the help of other imaging modalities. So we'll just go by some case presentations. So my first case is a 22-year-old female with complaints of headache, intermittent blurring of vision for 3 months, no associated complaints, no systemic illness. But she was giving a history that she was gaining weight since last 6 months, and when she presented to us, she was around 80 kg. Examination, visual acuity was 6/9, no RAPD, and this is how her disc looked like. So looking at this picture, we just went ahead to do her visual fields, and we could find there is an enlarged blind spot. We asked for a neuroimaging which came out to be normal. Had a neurologist consultation, did a lumbar puncture with CSF pressure coming to be 48 of H2O, and then, well, we clinched a diagnosis that it is a idiopathic intracranial hypertension. She was managed with tablet Diamox. So I'm not focusing more on the management, I'm just telling how the approach and clinical things will be. So we are coming to the second case. This is again a 25-year-old female, again presenting with complaints of headache, diminution of vision since last 2 months. When she came to us, she had a CT with her, imaging, which is quite normal. But she was rapidly losing her vision in the left eye, and it was around 660 when she was presenting to us. There was a RAPD, and this is how the fundus picture looked with us. So since she had a CT with us, we asked for a MRI, and the MRI was almost normal in this patient. We again went further with the neurologist consultation. We did a MR venography, and what exactly you can see in T1 post contrast, there was a narrowing of the right transverse sinus, suggestive of hypoplasia of the right transverse sinus. Probing into her, she gave that she had irregular menstruation. Asking for an abdominal CT, you can see that she had polycystic ovaries, and she came out to be a case of a polycystic ovary syndrome, that is PSOC. And what is very important, if you have patients of IAH, as we know that 15 to 46% of this child bearing age group, they can have this, and then managing them also with a lifestyle care, and not only taking care of this IH is very, very important. So that is something which we have to look into when we have patients with this at the age of childbearing age group, and to look whether they are having this PCOS syndrome. Coming to my third case, this is a 12-year-old female presented with inward deviation of the right eye since 15 days, associated with headache and vomiting. And she had esotropia of 30-degree ET, and there was a restriction of abduction in the right eye. Visual acuity was 612, 6/9, normal reacting pupils, and this is how her fundus picture was. So naturally thinking that can be there a rise in the ICT, we advise for a neuroimaging. And if you look at this, the T2 axial, you can see there is a intense surrounding lesion in the pons area. Asked for a contrast and MRI, so there is an increase in choline. And she came out to be a case of a pontine glioblastoma, which has to be immediately taken to the neurosurgeon. So some of the cases are very life-threatening. What I we want to stretch is that most common cause of a bilateral optic disc edema can be a papilledema, but not all disc edemas are papilledema. And very important, what we have to classify is if there is an increase in the intracranial pressure due to any of these causes, then only we can say it as papilledema. So not all disc edemas you can say that it is papilledema. Coming to this fourth case, you can see this is a routine case. A patient came to us with no complaints, just a routine checkup, 6/6 vision, and this is how the fundus picture is looking like. If you look at the optic disc, this has some bumpy things, not splinter hemorrhages, not typical, very, this margins are still clear, but there is some blurring of the disc margin. We went ahead to do a B scan, which is there in the OPD you can do, and you can see the hyperintense thing. We did a intense OCT, and this is a clear cut of a optic disc drusen. So patients with swollen optic nerve head and normal visual function, this ODD is the most common diagnosis. So these are certain things we read on, what are the true disc edema signs. I'm not going into detail. Coming to my fifth case, this was a 42-year-old female with intermittent blurring of vision. She was a known hypertension, but on intermittent medication. And she came all of a sudden with just a loss of vision. She had a very diminution of vision, and then she's coming to us, and this is how the fundus picture is. We just did a blood examination and a BP examination, and this is how her blood pressure was. It's a case of a hypertensive retinopathy. Just finishing with this case, which is a very interesting case. This was a very young child, a 4-year child, coming to us with the puffiness of the eyes, and then with a 6th nerve palsy. When we had a bilateral disc edema. Going further into a pediatric consultation, we did all the systemic examination, came out to be a nephrotic syndrome. Again, further, the patient was on treatment for nephrotic syndrome. Then there was a recurrence. Again, he came back with again a disc edema. And then we went on to do a MRI, and what we found, there was a dense central venous sinus thrombosis. So it's a very rare condition thing in this, and it can be a life-threatening, so which has to be taken into consideration. So unilateral, if you have a good vision, we know that it can be a pseudodisc edema. If you have a abnormal optic examination, these are like papillitis, we know, or CRVO or neuroretinitis can be the causes. We have different modalities with us now, autofluorescence or enhanced depth OCT, rule out papilledema, doing a MRI, MRV, and then if you have all this abnormal neuroimaging or a neuroimaging, you will be coming to click the diagnosis. So my take home message is all disc edema is not a papilledema, and detailed history taking, visual examination, neuroimaging, as well as multidisciplinary approach is very important for approaching this disc edemas. Thank you very much.
So that was a very nice presentation, Dr. Sucheta, and I think you can conclude it by saying that we need to go for neuroimaging in every patient with bilateral disc edema. But yes, if it tends to come out to be negative, we have to look for all the systemic factors as well.
Addition I want to do is, in certain cases, we have to rule out demyelinating disorders.
Yeah.
And for that, we may have to do visual evoked potential, VEP, which helps us in differentiating between the demyelinating disorders and rule out any other possible cause of optic neuritis because of multiple sclerosis.
Yeah, it was very less, so I wanted to focus
Yes.
on certain
But this is
cases.
also an important
But
investigation.
yeah, that is also in when we already know that demyelinating disease is there. You do a MRI, you have a diagnosis, you are clicking VP, and all further tests are always there where we can have a consultation with a neurologist and we work on it. So we do a VP in those cases.
Nice presentation.
Another interesting case was there of nephrotic syndrome.
Yeah.
Recurrent.
Yeah, that was a very interesting. Clicking the diagnosis was quite difficult, but we could save the patient because just thinking of nephrotic syndrome and just treating them was something when it came recurrent, why it was coming when it is already on treatment and all. So we were probed into the thing because any nephrotic syndrome just coming, we will not ask for a neuroimaging thing. So that was what, because BP was high initially, yes, nephrotic syndrome, it can be there and then treat it. But then again, why there was a recurrence, why there was a sixth nerve palsy in these cases, and then that deep vein thrombosis, and which is very rare, and that can be a life-threatening. So this was some reported thing. So
So
there
it
were
wasn't-
other things also, but that
was
sort
not-
of time I could not present much.
Okay, then that's fine. Nice presentation.
That was taken up, no? So anti-glaucoma coagulants were given, and it was taken up by the pediatric neurologist. Yeah.
Thank you. Thank
Yeah,
you
so
for
the
your-
interesting thing, one more thing, the interesting thing here was that the child had nephrotic syndrome, so maybe the child would have been treated, it may be because of, because of steroids, or it may be because of the high blood pressure the patient is having. So we have to go for neuroimaging because that only tells us whether it is because of these factors only.
Yeah, madam, but when patients come with this nephrotic syndromes, even they present with disc edema, initially they don't ask for a neuroimaging, mainly of the brain and all. Optic disc, yes, you saw there is a disc edema. You always think that there is a ICT, you can, but initially it came out to be normal. So that was the thing. Then recurrent, when he came for the second time, got admitted. So why it is, we probed into the thing. So the importance is we have to follow up these cases. Just treating them once and leaving it, saying that they have a normal neuroimaging with them is not the thing. That is what my stress is.
Yeah, so there can be multiple
Yeah.
factors playing.
Yeah.
That's good. Thank you.